Uh, Good evening, everyone. Today's topic is complications during hemodialysis. So, hemodialysis was first done successfully in humans in 1945, and since then, a lot of technological advancements have been made. But still, there are common acute complications that are encountered by physicians during the routine practice. I also not. So the most common complications during hemodialysis are hypotension, cramps, nausea and vomiting, headache, chest pain, back pain, and itching. Now, intradialytic hypotension, let's talk about it. It is associated with poor long-term outcomes, and it has shown increased mortality and also an increased rate of cardiac wall motion abnormalities during dialysis. So, what's the definition for IDH? That the systolic BP is less than 90, and or if there is a fall in systolic BP of around 20 to 30 millimeters of mercury. A low pre-dialysis blood pressure may be a marker of cardiac disease and heart with functional or structural abnormalities. Uh, this may be less able to compensate hemodynamically for fluid removal. It is also associated with an increased risk of access thrombosis. Now, what are the causes of intradialytic hypotension? It could be because of reduced effective circulating volume, impaired vasoconstriction, dialyzer reaction, air embolism, or hemolysis. So, what contributes towards reduced effective circulating volume? That could be because of excessive fluid removal, reduced plasma refilling rate, or hemorrhage. There can be a few cardiac factors like MI, arrhythmias, structural heart disease, pericardial tamponade, or myocardial stunning, which could contribute towards this hypotension. Impaired vasoconstriction could be because of patient-related factors or dialysis-related factors. In patient-related factors, it could be because of autonomic neuropathy, antihypertensive medications, lack of appropriate rise in the plasma norepinephrine, decreased sensitivity of the RAS system, food ingestion, tissue ischemia, sepsis, intradialytic venous pooling, increase in the core body temperature, anemia. These are all patient related factors, whereas dialysis related factors could be because of acetate dialysate vasodilation, which is adenosine mediated, low dialysate sodium or calcium concentrations, complement activation, or cytokine generation related. Then we have hemolysis, air embolism, and dialyzer reaction, which could contribute to this intradialytic hypotension. So blood pressure during hemodialysis normally does not decrease if the fluid is not removed. So any maneuver that slows the ultrafiltration rate, whether it be extending the weekly time on dialysis or reducing the weekly volume of fluid ingestion or increasing the volume of urine excreted, choosing target weight or dry weight carefully depending on the trends of blood pressures, tolerance to UF, or presence of peripheral edema. Appropriate dialysate solution sodium level, which is also called as sodium modeling. It's around 145 to 155. And blood volume control devices with feedback loop. So how do you manage interdialytic hypotension? You avoid large interdialytic weight gains by emphasizing salt restriction more compared to focusing on the fluid restriction, increasing the weekly treatment time, which decreases the required UF. In-center dialysis patients with fluid removal problems are often treated on a schedule like Monday, Wednesday, Friday, and Saturday. So that is how we can plan. Intradialytic hematocrit monitors may help recognize a dry weight that is too high. So a flatline hematocrit response, despite the fluid removal, indicates rapid blood compartment refilling and suggests fluid overload. Now, hypotension related to lack of vasoconstriction. So the degree of arterial constriction or total peripheral resistance is also important because TPR will determine the BP for any level of cardiac output. So what are the points that would affect this? That is a lower dialysis solution temperature. So ideally, the solution, a dialysis solution temperature should be one that maintains a patient's arterial blood temperature at its initial level throughout the dialysis. So levels of around 35.5 to 36 are the better choices. The tympanic membrane temperature is measured in few cases, and the dialysis solution temperature is set 0.5 degrees Celsius below this level. Now, avoid intradialytic food ingestion in hypotension-prone patients. So, eating during hemodialysis can precipitate or accentuate a fall in blood pressure, which is probably because of dilatation of the resistant vessels in the splanchnic bed. So, thereby it reduces the total peripheral resistance and increases the splanchnic venous capacity. So, this food effect on the BP probably lasts for around 2 hours. We should minimize tissue ischemia during dialysis. So during any type of hypotensive stress, the resulting tissue ischemia causes release of adenosine. Now this blocks the release of norepinephrine from the sympathetic nerve terminals and also has intrinsic vasodilator properties. So hypotension causing ischemia, leading to adenosine release, which causes an impaired norepinephrine release, causing vasodilatation and hence produces hypotension. Now, midodrine, which is an alpha adrenergic agonist, this reduces the frequency of IDH. So, a dose of around 10 milligram around 1.5 to 2 hours before dialysis session is typical. But also we use it frequently in our renal patients, and maximum of around 40 milligram of use of midodrine has been reported. Now, supine hypertension is the major dose limiting factor. Active cardiac ischemia is a contraindication, but not a simple coronary artery disease. Concomitant use of alpha adrenergic blockers renders the midodrine ineffective. Then we can see sertraline. At least there are 3 reports that have indicated that 4 to 6 weeks of therapy with SSRIs, this reduces the frequency of IDH. Others could be antihypertensive medications, which are administered prior to dialysis, adversely impacts the ability of the cardiovascular system to adjust to the volume removal. A low concentration of dialysis fluid potassium is associated with more frequent episodes of hypotension. This is probably because of the autonomic effects. There's one report where they had mentioned that there's no improvement with fludrocortisone in hypotensive patients with normal levels of adrenal hormones. And in one study, vasopressin infusion also reduced the incidence of intradialytic hypotension. Now, hypotension related to cardiac factors. Now, that could be because of diastolic dysfunction. So, a stiff, hypertrophied heart is especially prone to a reduction in the output when there is even a minor reduction in the filling pressures. Dialysis solution calcium concentration of around 1.75 mm increases cardiac contractility and helps maintain the intradialytic blood pressure better compared to that to a level of 1.25 mm, especially in patients with a cardiac disease. So how do we acutely manage this intradialytic hypotension? So the patient should be placed in Trendelenburg position, and a bolus of 0.9% saline could be around 100 ml or more. It should be rapidly administered through the bloodline. And the ultrafiltration rate should be reduced to 0, and it can be resumed later once the vital signs have been stabilized. So IDH may respond better to rapid administration of hypertonic saline over a period of 2 minutes. The tonicity induced increase in vasopressin levels is a likely basis for the differential effects. Now, another complication would be muscle cramps. The pathogenesis is unknown, but there are four most important predisposing factors for it. That is hypotension, hypovolemia, filtration rate, and use of low sodium dialysis solution. It is more common in patients with a low cardiac index. Uh, Diagnostically obscure elevations in serum CPK levels on routine monthly lab tests is what we'd found out. Hypomagnesemia can cause treatment-resistant muscle cramping during dialysis. Hypocalcemia, especially in patients treated with relatively low calcium dialysis solution and calcium-free phosphate binders or cinacalcet. Now, when hypotension and muscle cramps occur concomitantly, both may respond to the treatment with normal saline. Hypertonic solutions may be more effective in dilating the muscle blood vessels. Hypertonic glucose may also be used in non-diabetic patients. Mannitol may accumulate in dialysis patients, particularly when administered late in the treatment. And that's the time period where these cramps actually occur. So how do you prevent this? You can prevent it by doing some stretching exercises. Dialysate sodium. The sodium gradient of the solution can definitely reduce the cramps. Dilysate magnesium. So you should avoid low pre-dialysis levels of magnesium, calcium, and potassium, which may be helpful. It has also been reported that 1 milligram per day of biotin may improve the cramps. And there was few studies that reported about results that could be achieved with carnitine, oxazepam, and vitamin E. Compression devices may be of benefit. Quinine earlier they had tried for, but it is now considered inadvisable because of its association with thrombocytopenia, hypersensitivity reactions, and prolongation of QT interval. Nausea and vomiting. Now, this occurs in up to 10% of routine dialysis treatments. Could be an early manifestation of disequilibrium syndrome. Both type A and type B varieties of dialyzer reactions can cause nausea and vomiting. Gastroparesis, which is very commonly seen in diabetic patients, but also seen in non-diabetics, is exacerbated by hemodialysis and may play a role in some patients. Contaminated or incorrectly formulated dialysis solution may cause nausea and vomiting. So the management part, this may be particularly problematic when associated with hypotension-induced reduction in the level of consciousness owing to risk of aspiration. So how do you prevent this? You treat the hypotension, intradialytic hypotension part, and in addition to that, even if the symptoms persist, then you treat with metoclopramide. Now, dialysis may precipitate migraine headaches in those with a history of the particular disorder. So, with atypical or particularly severe headaches, other neurological cause should be ruled out. Acetaminophen can be given during dialysis. People with a history of migraine disorder or caffeine withdrawal should be treated symptomatically or supplemented with a strong coffee so that they don't have these withdrawal symptoms. Chest pain and backache. This cause is unknown. There's no specific management or prevention strategy. Though switching to a different type of different variety of dialyzer membrane may be of benefit. The occurrence of angina during dialysis is common and must be considered in the differential diagnosis along with other potential causes of chest pain. Itching. Itching is a common problem in dialysis patients, which is sometimes precipitated by or exacerbated by dialysis. It manifests of low-grade hypersensitivity to dialyzer or blood circuit components. So, general moisturizing and lubrication of the skin using emollients is recommended. One should make sure that the dialysis is also adequate. It is associated with elevated serum calcium or phosphorus levels or substantially elevated parathormone levels. So reductions in the levels of these electrolytes are indicated. Standard symptomatic treatment using antihistaminics is useful. Also, we could try gabapentin, ultraviolet light B therapy, oral charcoal, or nalfurafine, which might be the next line of therapy, followed by naltrexone or tacrolimus ointment. So there's this flow chart where you exclude other causes of pruritus. If it is the pruritus is severe, then you assess the type, quality of dialysis, and accordingly increase the dose of dialysis if required. If it's simple moisturizing and ointment, it settles, then it's fine. Next, if you increase the dose of dialysis, despite doing that, it still persists, then along with the moisturizing with emollients, along with that, you can combine these various steps. That's gabapentin, ultraviolet light, phototherapy, charcoal, nalfurafine. And despite using all this, still if it persists, then you can try on naltrexone, tacrolimus ointment. And even though it further, if it persists, then you need to consider about kidney transplantation. A bit about disequilibrium syndrome. It is associated with the characteristic EEG findings that can occur either during or following a dialysis therapy. The early manifestations would be nausea, vomiting, restlessness, and headache. More serious manifestations would include seizures, obtundation, and coma. So it is related to an acute increase in the brain water content. So there are acute changes in the pH of the CSF during dialysis, because of which this occurs. So how do you manage? So for mild disequilibrium, the treatment is symptomatic. The blood flow rate should be reduced to decrease the efficiency of solute removal and pH change. Consideration should be given to terminate the dialysis session earlier than planned. Hypertonic sodium chloride or glucose solutions can be administered as for treatment of muscle cramps. Now, severe disequilibrium, like when we have seizures or obtundations or coma, then dialysis should be stopped. Supportive treatment, airway should be controlled. If required, the patient would need ventilation. So, supportive and symptomatic treatment for severe disequilibrium. Intravenous mannitol may be of benefit. And if coma is because of disequilibrium, then the patient should improve within 24 hours. How can you prevent this in an acute dialysis setting? So when you plan dialysis for an acutely uremic patient, avoid aggressive treatment session. So your target reduction in the plasma urea nitrogen level should initially be limited to about 40%. Use of a low sodium dialysis solution may exacerbate your cerebral edema and should be avoided. In hypernatremic patients, one should not attempt to correct the plasma sodium concentration and uremia at the same time. So it is safest to dialyze a hypernatremic patient initially with a dialysis solution of the sodium value, which is close to the plasma level. And then you correct the hypernatremia slowly post-dialysis by administering 5% dextrose. Now, this was in an acute dialysis setting. In a chronic dialysis setting, the incidence can be minimized by using a dialysis solution with a sodium concentration of around 140 ml. So what could be, there's a flow chart which shows causes of hemodialysis associated seizures, which could be because of drugs, could be because of metabolic parameters like hypocalcemia, hypomagnesemia, hypoglycemia, then hyperosmolarity caused by hypernatremia, severe acidosis, uremic encephalopathy, dialysis disequilibrium syndrome, hypotensive encephalopathy, and because of sustained hypotension, the cerebral anoxia that occurs, focal neurological disease, other toxins like acute aluminum intoxication or alcohol withdrawal. Now let's see about dialyzer reactions. Uh, it is divided into type A and type B. So type A is the anaphylactic type, where a full-blown severe reaction occurs. There can be dyspnea, a feeling of warmth at the fistula site or throughout the body. These are the common presenting symptoms. Cardiac arrest and even death may supervene. So milder cases might present with itching, urticaria, cough, sneezing, coryza, or watery eyes. There can be gastrointestinal manifestations such as abdominal cramping or diarrhea. Patients with a history of atopy or eosinophilia are prone to develop these reactions. So the symptoms might start during the first few minutes of dialysis, but onset may occasionally be delayed for up to 30 minutes or more. There can be a contaminated dialysis solution, which particularly can occur with the use of high flux dialyzers. There can be this dialysis solution contaminated with high levels of bacteria and endotoxin. So these reactions occur within 2 minutes of initiating the dialysis, or it can be a delayed one that is around 15 to 30 minutes later, means after starting the dialysis. So that can be a complement mediated reaction. So the common symptoms are fever with chills, and higher the bacteria and endotoxin levels are there, greater the risk of reaction. So something about reuse. This type of anaphylactic type dialyzer reactions, it has occurred in a reuse setting, and this problem has been linked to inadequate dialyzer disinfection during this procedure. Heparin has also been associated with allergic reactions. Now, identifying the actual cause of a dialyzer reaction is frequently not possible. It is safest to stop the dialysis immediately, clamp the blood lines, and discard the dialyzer. And keep in mind that this contained or contaminated blood, it should not be returned back to the patient. So immediate cardiorespiratory support, if the reaction is anaphylactic reaction is very severe, so there could be a possibility of cardiorespiratory arrest or requiring support. So we need to treat with intravenous antihistaminics, steroids, epinephrine, and airway support. For all patients, proper rinsing of the dialyzers prior to use is important to eliminate the residual ethylene oxide and other putative allergens. In patient with a history of type A reaction to ethylene oxide, sterilized dialyzer, basically the dialyzer which is sterilized with ethylene oxide, you can change it to gamma irradiated steam sterilized or electronic beam sterilized dialyzer. There are non-specific type B dialyzer reactions also. The symptoms would manifest after 20 to 40 minutes after starting the dialysis. This could be because of complement activation, and it presents as chest pain or backache or anaphylactic, this occurs less frequently with the reused dialyzer compared to the new dialyzer. Now, other causes of chest pain and backache also should be excluded, and you manage it supportively by supplementing oxygen if there is some suspicion of myocardial ischemia. Dialysis can usually be continued in such scenario, as symptoms may invariably abate after the first hour. So we could prevent by trying a different dialyzer membrane. So this is a time scale along with this table shows a pathogenesis, what could be the etiology, and how do you manage and prevent it. So dialyzer reaction could start within 5 to 10 minutes of starting the dialysis. It could be anaphylaxis kind of reaction, which is IgE mediated. Could happen with the first use of dialyzer or with reuse. But how do you manage this is that you do not return, you stop the dialysis, do not return the extracorporeal blood to the patient, and treat with epinephrine, corticosteroids, and antihistaminics. And how you can prevent this is that you rinse dialyzer before the use, or you use gamma ray or steam sterilized dialyzer, discontinue the reuse, or you this is it could also be anaphylactoid type, which can be bradykinin mediated or histamine mediated. So for that, you avoid unmodified AN69 dialyzers with AC inhibitors. You treat or discontinue reuse with of such kind of dialyzers, and use a test dose for iron dextran, which is a histaminic kind of reaction. Also, 20 to 40 minutes after starting the dialysis, you can see a mild reaction that can be complement mediated. So in such case, you can continue the dialysis because symptoms would usually settle in 1 hour. And how do you prevent this is that you use non-cellulose dialyzer membranes. And the third type of dialysis reaction can happen at any point of time during the dialysis, which can be a pyrogenic reaction due to bacterial contamination. So you stop the dialysis, send blood cultures. If hypotension is persistently there, escalate the antibiotics and give antipyretics. Now a bit about hemolysis. The symptoms of hemolysis could be back pain, tightness in the chest, and shortness of breath. Now, there could be a deepening of the skin pigmentation that can occur. But visually, what you see is there is a portwine appearance of the blood in the venous bloodline and a pink discoloration of the plasma in centrifuged blood samples. And there is a marked fall in the hematocrit. So if massive hemolysis is not detected early, then hyperkalemia can result owing to release of potassium from the hemolyzed erythrocytes, which could lead to muscle weakness or ECG abnormalities and ultimately cardiac arrest. So it can occur in two primary settings that can be an obstruction or narrowing in the bloodline, catheter or needle, or there could be a problem with the dialysis solution. So the possibility of hemolysis induced by the combination of G6PD deficiency and pre-dialysis quinine sulfate therapy should be considered. So this bloodline obstruction or narrowing could be because of kinks in the arterial bloodline. So we need to see that. And there was an epidemic of hemolysis that was reported owing to the manufacturing defects in the link between the dialyzer outlet bloodline and the venous air trap chamber. Now, routine blood pressure monitoring will call attention to many, but not all such problems. There can be problem with dialysis solution, that is overheated dialysis solution, hypotonic dialysis solution, dialysis solution that's contaminated with formaldehyde, bleach, chloramine, which could be because from the city water supply, or from the piping contaminated with copper, fluorides or nitrates, zinc or hydrogen peroxide. So what do we do? The blood pump should be stopped immediately and the blood lines clamped. The hemolyzed blood should not be reinfused because it would be containing a very high potassium content. So, and also in the meanwhile, one should be prepared to treat the resultant hyperkalemia and possible drop in hematocrit. So delayed hemolysis of injured erythrocytes may continue for some time after the dialysis session also. Severe hyperkalemia may occur and this may require additional session of dialysis. So what are the labs that we would send for? It is a CBC, a retic count, levels of haptoglobin, free hemoglobin, LDH, and myth of hemoglobin. Now, the dialysis solution water, if what do you say? It has to be sent for assessment and it has to be look for nitrates, any metals, chloramine, any residual sterilant. So that is what the water has to be assessed for. And how do you prevent this? So unless there is a problem in an obstruction in the blood path or a faulty roller pump that can cause excessive blood trauma, the cause of hemolysis must be assumed to be in the dialysis solution, and samples of dialysis solution must be investigated to determine the cause. So causes of the hemolysis in this table form, you can see when a patient is having some traumatic fragmentation, incorrect osmolarity of the dialysate, thermal damage by overheat or underheat dialysate temperature, oxidative damage because of methemoglobinemia, chloramines, nitrites, other drugs, uh, reductive damage because of formaldehyde, cell membrane fragility because of insufficient dialysis or zinc deficiency, microangiopathy, G6PD deficiency, or elements that would interfere with the red cell metabolism like copper, aluminum, formaldehyde, or hypophosphatemia. And the last complication would be air embolism, which the symptoms would be like in seated patients, the infused air, it tends to migrate towards the cerebral venous system, whereas in recumbent patients, the air tends to enter the heart. So how do you identify this? In the venous bloodline of the dialyzer, you can see you would be able to see a foam. So if the air has gone into the heart, on auscultation, you'll be able to hear a kind of churning sound. And how does or from where does this enter is the site of arterial needle insertion, the pre-pump arterial tubing segment, or an inadvertently opened end of a central venous catheter. This could be the cause of air embolism. But how do you manage that? So the first step is that you clamp the venous bloodline and stop the blood pump, and the patient is immediately placed in a recumbent position on the left side with the chest and head tilted downward. You administer 100% oxygen by mask, or if there's a cardiorespiratory arrest, then you protect the airway. Aspiration of air from the atrium or ventricle with a percutaneously inserted needle, or cardiac catheterization may be needed if the volume of air is too much. That's all from my side. Thank you.
Okay. Resma, one after the another will just whatever the points has been missed or we need some clarification.
Yes, sir.
That we can deduce at this moment. Okay, one is air embolism. You go back to the slides. I think better idea will be to just go one after the another. So how much air usually is required to cause air embolism?
How much volume I couldn't find out, sir.
Is there in Robbins pathology. In the pathology book, it has been there for ages. So on an average, it is around 1 ml per kg of body. Okay.
So 1
1
ml per kg.
kg of body weight.
Body weight. Okay.
So 1 ml per kg of body weight, if it is more than that, or almost equal to that, or almost approaching that, then you can have air embolism.
Okay.
So the next question is that why you want to place the patient in that position? You told no, left lateral position with head and neck to be in the downwards, almost like a Trendelin means head and neck has to be, chest to be down. So why it is like that? Why the position has been mentioned like that?
So that the air would, what do you say, travel upwards and you're able to aspirate through the catheter.
Air has gone inside the heart, you know now. The catheter is in the heart.
Yes, sir.
Or the fistula, if it is there, it has gone through the venous circulation into the right side of the heart. So why you want to keep the patient in left lateral with a chest and neck and the head down? That is also written over there. Anybody else?
So the air does not enter the systemic circulation,
So
like
it
it
is in the,
remains in the.
see, we are talking about the venous side of the heart, correct? We don't puncture the arterial limb, any period of time during dialysis. What we are doing is basically we are puncturing the venous side, either AV fistula or the IJV. Both are basically in the vein. So vein will drain to where? To the right side of the heart. Right side of the heart is not systemic circulation, no? It is in the pulmonary circulation, correct?
Right, sir.
Yes, sir.
So what you are doing at this moment is basically that if the air goes inside, then it goes into the pulmonary circulation and cause more of a in the pulmonary artery, and it goes into the periphery and causes blockage. It is like a emboli. That's why the name is embolization. So it is behaving like a emboli, like you see in thrombus migration inside the heart also. DVT and other thing, whatever the effect is, it will cause the same effect. Okay. So right side of the heart is the problem. But why they have kept it in the left side heart? Why it is not in the left side taunt position? Where the air should float. Air is always will float towards the upper part, no?
Yeah, so it will rather float on the upper part and on the right side of the heart.
So the aim is basically trapping the air in the ventricular apex, right ventricular apex. Okay. So that's why you are turning the patient to the left and keeping the right upper ventricular apex in the upper side, so that the air goes inside and gets trapped over there. Air cannot go down since air has the property of floating up. It has got, there is no gravity related yet to the air. Since whenever you see a glass of water, half a glass of water, air will be filled in the upper part, the water will be in the down. It is due to the gravitational pull, but air doesn't qualify for that since it floats. Okay, so that's why the right side of the apex of the ventricle, it will get trapped. It will not go into the pulmonary circulation. If at all there is a arterial septal defect or a ventricular septal defect, which to right to left, left to right sound, or sorry, right to left sound, then only you can have this embolization into the brain and other circulation, systemic circulation. Otherwise, it is, if you see scientifically, it cannot go actually. It has to be in the pulmonary circulation. Correct?
Yes, sir.
So that is one explanation I wanted to make. One. And when you trap the air in that position, you have to give high flow oxygen, maybe with very high flow mask, what you are using for during the hypoxia itself, high flow mask, you can deliver the high amount of oxygen inside. And gradually what happens, the air in the apex of the right ventricle gets absorbed. So rarely, we have not seen patients going into requiring cardiac catheterization. Usually they recover after a few days if you give them this position and keep them with high flow mask. Whatever small bubbles have gone inside causing any hypoxia, that will be resolved and the air gets absorbed. The most important point for this air embolism to occur is basically what you said was opening of the central venous axis. How it can happen? You have written, no? Open end of central venous catheter. Usually central venous catheter will not be opened during dialysis. Rarely you can find that type of thing. What is more important in this scenario? If you put, since there will be some amount of, if you put the for giving any saline or bolus of saline into the venous system, okay, in the tubings or the it will be in the arterial system, correct? So if it will be in the arterial system, it will be in the venous system. So so if you are keeping that saline, if you are giving saline and kept that thing open, you have given it for hypotension and you gave the saline for 100 ml or 200 ml and you kept that saline bottle open. And what happens earlier days, you are using usually the glass bottles, and where you have to put the needle inside to put the air inside the air. Nowadays also what the sisters do for free flow of the saline, they puncture the upper part of the saline bottle, which is plastic. But here I think what good thing we have done nowadays in Reliance is that we are using collapsing chambers. Correct. There is no way you can put any needle inside to puncture it. Okay, so that air can go inside if you have not clamped it properly and cause air embolism. So that is the commonest thing we have seen. It is a practical thing which I have seen. Opening of the central venous catheter is rare, since all the unless until you have not properly put the lever lock connection of the arterial and the venous end. There is a leak in the arterial and there is a leak. So similarly, if there is any third port which is there, let us say you have put a triple lumen catheter and one port you forgot to clamp down. So in that scenario also, you can have air embolism due to that, if it is open. So these are some of the practical things you have to know. Okay.
Yes,
Then
sir.
to I think hemolysis part you have done well. I think there should not be any confusion in that. Can you go to DDS, dialysis disequilibrium syndrome?
Disequilibrium.
Yeah, that figure you have shown na in the other slide.
This one, sir.
Yeah. So what do you mean by dialysis disequilibrium syndrome? It is basically a syndrome which is happening due to osmotic imbalance. Okay. So pH change happens, but pH change more important is osmotic imbalance rather than the pH change. Both can be contributed. I'm not saying that that will not happen, but pH, besides pH change, there is a osmotic imbalance which is very much essential to happen. What happens here? You can see here. Okay, so there is a brain cell which has been depicted here in the right side top corner, which you have shown. Okay, so urea is a molecule which is osmotically active substance, correct? That's why we keep urea in the plasma osmolality calculation. So urea is a osmotically active substance. So whenever the uremic patient is there with the uremic value in, so there will be equilibrated, the urea concentration will be equilibrated in the intracellular fluid as well as the extracellular fluid. And intracellular fluid and extracellular fluid, as you know, will be 2/3 and 1/3 out of extracellular fluid, which is same. I don't know whether I can, whether my pointer is, you can see.
No, sir. I can do that.
Yeah. That is the intracellular fluid. Just nearby is the extracellular fluid. The extracellular fluid has got two compartments. Okay, one is interstitial compartment, the other one is intravascular compartment. So ICF is 2/3 and extracellular fluid compartment is 1/3, out of which 1/3 is intravascular fluid compartment and another 2/3 is extracellular fluid compartment. Okay, that is interstitial compartment. So when you are doing dialysis in a rapid session, you are reducing the urea in the intravascular fluid compartment. And that is much more higher than what the urea rebound happens. Like you said, now urea should come from the intracellular compartment to equilibrate with the intravascular compartment. But since urea is not happening so fast, but you are removing the urea very rapidly, so the intravascular fluid compartment, the urea is rapidly removed. And that causes a decreased plasma osmolality in the intravascular compartment. And what will happen for that? The resultant effect is basically to reduce the urea in the intercellular compartment in the brain cells. So what will happen? The water will move from the extracellular fluid into the intracellular fluid. So that will cause cerebral edema or the brain swelling. The cell will increase in size. And this cerebral edema causes seizures and other whatever you have described. Okay. So what are the ways by which we can reduce the disequilibrium syndrome? Usually in acute care setting, like you are facing acute kidney injury patients, rapidly removing the urea doesn't cause disequilibrium. It happens when there is a chronic kidney injury, chronic kidney disease, and the patient is having very high amount of urea reserve in the body. So that's why there are certain criteria and risk factors which you have to see. And what are the risk factors? One is the urea. If the urea is more than 200 milligram percent, 200 to 300 milligram percent, then chances of disequilibrium syndrome is more. If the patient body surface area is low, but the urea is disproportionately high, then also chances of disequilibrium syndrome is more. If the patient is having hypokalemia with a high urea level, then chances of disequilibrium is more. And in the plasma osmolality, when you calculate along with that, one is glucose is there and one is sodium is there. So if there is a patient who is having low sodium with high urea level, then chances of disequilibrium syndrome is more. So these are some of the risk factors you have to see prior to starting the dialysis, so that if you go slow in that, the chances of DDS will be less. The other way will be to reduce the clearance of urea or the small solutes rapidly. So how to do that? One is you keep the blood flow to be very low. So that's why we ask the patient in the initial period when we start the dialysis, we give the blood flow rate of around 140, 150, 175 kind of thing. That is the reason why it is like this. That you are taking out the urea not rapidly but slowly, and shorten the duration of dialysis. It cannot be in one day. You cannot go for 4 hours dialysis kind of thing. It has to be, if it is a fast initiation of dialysis, I'm not talking about acute kidney injury, metabolic acidosis, where it happens quickly within few hours or days period of time, where rapid urea removal also will not affect much. It depends upon the rate of rise and how slowly it has risen, and also the body has adjusted to it, or the brain has adjusted to it. So that is when the disequilibrium happens in that scenario. So in that scenario, we give 2 hours, 2.5 hours of dialysis first day, then 3 hours next day, then give a gap, then give another 4 hours another day. The other way of doing it is reducing the dialyzer size. Let us say that we are using F8 dialyzer for increased urea clearance or increased solute clearance, so that there will be rapid correction of solutes. So that is detrimental. So in this scenario, you have to calculate the body surface area, how much is the patient size, then accordingly use the smallest possible dialyzer. And in children also it has to be like that. Children size and surface area has to be proportionate to the dialyzer surface area. You cannot dialyze a child with 1.6 or 1.8 meters square of body surface area. It will cause more dialysis disequilibrium. Okay. So then these are the prevention and risk factors we have talked about, which was not clear in your slides. Next, we will go to hypotension. Correct. We'll go to part.
Dash sir, one question.
Yes.
Ketan here.
Okay.
If is there any one thing you told that about dialyzing with a low filter? I'm talking about dialysis disequilibrium syndrome, but some centers sometimes use prophylactically mannitol when they start dialysis. It is the correct practice?
That has been already pointed out in the slides, no?
Yeah, but is
It
the
is
practice
mannitol.
is correct? Do you think that benefits in real life?
Yes, mannitol sometimes you can use, but mannitol has got its own side effects.
Okay.
So that's why we don't prefer. When we can modify with our other maneuvers, why to give mannitol always? Many people also give levetiracetam so that
Uh-huh.
seizures will not happen and other things will not happen. So that is also, I don't think so. If you do proper dialysis with proper guidelines, then it will not happen.
Okay.
Okay. Only you have to see what are the risk factors. If the child is, and we don't have that size, let us say that you have 1.1 meter square of surface area of dialyzer and the child is around uh, total surface area might be around 0.6 to 0.8 meter square. So in that scenario, uh, you can actually load the patient with mannitol. But that also you have to take precautions. Don't give much of, since the patient can go into pulmonary edema. Mannitol related reactions also are known. So, and especially so you cannot actually escape. Although mannitol is a dialysable substance, you have to give time. No, if you are giving 2 hours of dialysis, mannitol might not be taken out from the blood in that duration of time. So there is always a chance of causing harm to the body rather than benefit. So nowadays, the practice of giving mannitol has been reduced, except in children. In children. So children also another factor is why we are much more worried about it is basically that disproportionate skull size to the brain. So in adults, the skull has uh, increased its size has been increased. The skull also grows with time, no, with the child when it goes to the adult phase. So till 40, 12 to 14 years of age, skull also grows along with the brain. But the brain size is in case of children to the skull ratio is very high. So it is basically a compressed kind of thing. So slightest amount of osmotic fluctuation can cause cerebral edema and cause more of neurological issues. So that's why we try to minimize as much as possible that situation. So mannitol in that scenario is conventionally given in that scenario. I think I have explained appropriately.
I agree, sir. I agree. We have not seen that practices in the recent past about mannitol.
Yeah, but in children, you sometimes you have to use it. It is due to the disproportionate skull and brain ratio. And hyponatremia in children also is very tricky situation. It is for the same reason. They can go into cerebral edema, they can go into osmotic demyelination quite often. Okay. So in the next is intradialytic hypotension, correct? So why, Resma, I have a question for you. Why we are using saline, not other isotonic solutions? You have ringer lactate, you have that what is that formula which we commonly use nowadays? Isolite P or something like that. Hello.
So, because of
Why
the
not
sodium,
5% dextrose? Why not 25% dextrose? Why not giving the other formulations which usually use in case of hypovolemia in acute kidney injury scenario? Sorry, in hypotension, shock scenario.
because of the sodium content of the normal saline, sir, compared to
What is the
RL or
sodium content? Just hello.
around 154.
हाँ बोलो. कल 5:30 बजे. नेक्स्ट 1 सितंबर से होएगा ना. नेक्स्ट वीक से कर दो. हेलो.
Yes, sir.
So it is the same thing what you are whether you can say that normal saline is a isotonic or isosmolar.
The
Is it
sodium content
isotonic?
is 154, sir.
One,
Sorry, 514.
correct.
For 154.
154 millimoles per liter.
Hmm.
Whereas our plasma sodium is 140 to 140.
145. Hmm.
So what is it? It is hypertonic or hypotonic? So almost 10 millimoles more, no?
Slightly hypotonic compared to our plasma sodium levels.
Hyper or hypo? इतना क्या सोचना? Hyper है ना वो? 154.
हाँ, hyper ही है, 10 का difference है sir, and that is more compared to our plasma sodium.
Correct. So then we are giving not iso. Why it is called as normal saline then? We are talking about normal saline, whereas we are using hypertonic to the plasma. It is not normal. So that we can discuss at a later period of time why it is called as normal saline. Now let us discuss about why we use saline. Okay. And that also applies to your concept of hypernatremia correction. That also is applicable. So when we are talking about means total body water, okay. So how, or the total body water is distributed how much? How? Like you said, given that example of in the dialysis disequilibrium syndrome, there is a intracellular component, there is a extracellular component, and extracellular component is divided into interstitial component and intravascular component. Okay. So if blood is or the fluid is distributed inside your body, or any fluid you are giving, that will be proportionately distributed accordingly. Okay. So intracellular component is 2/3. Then 1/3 will be extracellular component. Out of extracellular component, interstitial will be 2/3, and the intravascular component will be 1/3. Okay. So when you are giving 5% dextrose, so that will be distributed as water, since it is C6H12O6, correct? C6H12O6, that will be converted to carbon dioxide and water, and carbon dioxide will be excreted out by the lungs, and the water will remain inside your body. Correct? And
Intravascular. Yes, sir.
water has the property, it doesn't have any selective permeability. It can just permeate anywhere in our body. Since water is not the, all other plasma membrane can keep certain solutes or solution out, but water is freely permeable. So if you give 1 liter of dextrose, it will be redistributed into, so 666 ml will be going inside the intracellular compartment, and 333 ml will go into the extracellular compartment. So out of which 1/3 will be intravascular. So 111 ml will go into the intravascular compartment, and 222 ml will go into the interstitial compartment. Correct. So 1 liter of fluid you are giving, and intravascular volume, how much it is expanding? Only 100 ml. So that's why hypotonic solutions are not given for increase the higher blood pressure or hypotension. It has to be isotonic fluid, or it is a hypotonic fluid. Like you said, 3% saline were used. Yes, we can use that. But if the salt load is very high, then it will be counterproductive. Rather than that, why not give a isotonic fluid, that is normal saline. I will discuss it later why it is called as isotonic, although it is regarded as hypertonic, 154 millimoles. So whereas normal saline, if you take into account, it will be distributed 96% intravascular. Okay, so that 200 ml what you are giving will remain in the intravascular compartment. It will not go outside. That's why it is expansion will happen, and that will reduce the hypotension. So that is the rationality behind giving saline rather than 25% dextrose or any other fluids in hypotension. Understood?
Yes, sir.
Okay. Okay, now coming into the, you have mentioned about accrete parameters in hypotension. Hematocrit measurement, correct? You have taken into that. In the management, hematocrit.
Last point, intradialytic
Yeah,
hematocrit.
what do you mean in that sentence? Intradialytic hematocrit monitors may help recognize dry weight that is too high, a flatline hematocrit response. What do you mean by that? Whether we are doing it here in Reliance?
Sir,
We are not
sir,
doing.
what is the question?
Pardon me, Ketan?
Sir, can you repeat the question?
No, this sentence we have seen, na, that last sentence. Intradialytic hematocrit monitors may recognize a dry weight that is too high, a flatline hematocrit response, a lack of increase during dialysis despite fluid removal indicates rapid blood compartment refilling, suggests fluid overload. That has been mentioned over there. What does that mean?
I'm not aware, sir. I'm not aware.
Resma, have you read this, or you have just overlooked it?
Not read about this, sir.
Yeah, that is a tricky situation. Means not everybody knows about it, but I have seen those monitors, so that's why I am just emphasizing that. So there is a separate monitor which will be attached to the dialysis machine. Okay, so it will be monitoring your hematocrit level at real time, and it will give you a graph. And what the graph says, Our hematocrit is what? How much is the hematocrit? Normal hematocrit? What is the normal hematocrit of our
Up
body?
to 40%.
44%, yes. So it will give you a hematocrit reading that this is at the start of beginning of the dialysis, the hematocrit reading is like 44. Okay. Now you have started the dialysis and you started or the patient fluid removal. And that fluid removal, when you are seeing that there is a rise of hematocrit, that is meaning what? That meant that you are taking out more water than the venous refilling is happening. So the venous refilling is basically that from the intracellular or the interstitial compartment, the fluid will come into or the water will come from that segment to the intravascular compartment. If your filling rate is proportional to your ultrafiltration rate, then there will be no drop in the blood pressure. But if your venous refilling rate is low and proportionately your ultrafiltration rate is high, then there is a chance that the blood pressure will go down. So how it will be reflected? Let us say that the patient's initiation of dialysis, the hematocrit says that it is 0.44. Now after dialysis, it has increased to 0.48. So that indicates that the refilling rate is not proportionate. So you reduce the ultrafiltration rate either by reducing the ultrafiltration goal or by increasing the duration of the dialysis. That is how you can, if the same ultrafiltration you want to take out, but with increased duration, then proportionately the rate will also be less. So that is what it is saying. A flat line response indicates that still the patient is having volume overload. You can have enough fluid to get removed from your body. However, if the flat line increases with time, that indicates that you have to resort to reducing the ultrafiltration. So that is what the hematocrit says. But the problem
So,
is,
sir,
tell me.
is this that we start of the dialysis and end of dialysis, or is it like we can monitor
No. It is
after
a
2 hours
continuous
dialysis,
monitor.
after 10 days?
It is a continuous monitor. It is attached. It is a sensor, and there is a monitor with the graph is there, which will be there put. That is a small, like your parameters, multi-para monitor, no? Like that small monitor will be there above the dialysis machine. It will be fitted. And there, continuous monitoring, real-time monitoring will be done.
So, mid dialysis session, then can we alter the
No, it
ultra?
is second to second monitoring or minute to minute monitoring.
Okay.
So continuous monitoring, it will be a continuous monitoring. So any
So-
time frame you are seeing that the crit line is going up, then you reduce the ultrafiltration.
Okay. Yeah.
So the problem with that is, unfortunately, evidence didn't prove that crit monitoring is beneficial. Actually, it has to be in the initial period, whatever the evidence showed, maybe those are flawed or something like that. Scientifically saying it is actually giving us clue that how much fluid has to be removed, you can see by yourself. But in evidence wise, it didn't prove that crit monitoring was helpful in reducing the hypotension. So that's why it was not a common practice. in using hematocrit monitors. However, I still feel that in acute care setting, it is much more important in the sense that when we cannot weigh the patient, especially so in patients who are on ventilator, who are having uh, so much fluid and other things, resuscitation has been done, and we don't know how much is the fluid removal is required, how much is the appropriate rate. So I think we lack the evidence, but it was a flawed design, and actually somebody can use this as a trial in future if somebody wants to. We have to have just the hematocrit monitor and see during the CRRT and SLADE whether it is helpful or not. That pilot study we can do actually.
Sir, one question. If you are transfusing a blood to the patient during this, then
That will affect, obviously that will affect.
yeah, yeah.
There are two
Okay.
things which has been seen. If there is a blood loss is happening anywhere, either in the GI tract or blood loss which has been not on invisible blood loss, whether it is any compartment or anywhere it is there, then it doesn't help. It doesn't
Yeah.
help.
And sir, in the fluid choice, you commented very nicely about dextrose and fluids. But what is your thought about albumin? Now, and one question number one is, yeah, albumin is better over isotonic saline, one. And if albumin is a preferred choice, which 5% or 20%?
See, albumin is a substance. One is the resource limited setting we are doing. Still, we should not be forgetting that we are doing dialysis, other things in a resource limited setting. Okay. So in Western countries also, they utilize the resources in a very effective manner. Since most of the time you will see that the government will be paying for the so the albumin will help when there is a hypoalbuminemia. But why albumin will help when the albumin level is normal? We are dealing with the water only, fluid related. So in that scenario, volume expansion wise, I think the rapid expansion of intravascular volume will be much more better with saline rather than albumin, where albumin will take time to recompartmentalize the fluid. Let us say that albumin you have given, and you are expecting that the patient's intracellular water will come to the intravascular compartment. It will take time. So I don't think so in acute care setting like hypotension, intradialytic hypotension, it is effective. That answers the question.
Yeah, but actually, no. Flip side is we tend to use that left, right, center in our day-to-day practice.
No, that is for whenever you are thinking about not intravascular volume, short duration. Let us say the patient is on dialysis and we are thinking that there is an intradialytic hypotension has happened. There, albumin will not give you any. Rather, albumin, what we are giving is basically when there is a to prevent it, intradialytical hypotension. And prevention is basically it takes few hours, half an hour to 1 hour time frame is required. And here we have to correct it immediately within minutes.
Mm-hmm. Yeah, I agree.
Okay.
Right.
Yeah. Okay. So now next, Usha, that is regarding the sodium profiling. Dialysate sodium, you have mentioned one. One is calcium, you have mentioned. The other one is dialysate sodium.
Sodium modeling, yes.
Sodium modeling, you have presented.
So usually they keep it around 145, na, sir?
You have mentioned 145 to 155 actually were that is not possible in our dialysis machine. The dialysis machine up to 148 it can go. So you cannot go beyond that. It will cause more. It can cause sudden shrinkage of brain matter and will cause more of hazard and salt gain also. Another thing I wanted to point out was basically use of 3% saline, you said, in 1 year. So,
Yes, sir.
3% saline and sodium modeling. Here you have written sodium modeling 145 to 155. So, usually we keep it at around 148. Okay, 148, then we tend to decrease that. What is the mean of modeling? What is modeling? Have you seen the people on the ramps modeling? Model who are doing in the ramps? They are so much thin body build. Correct?
Yes, sir.
They have to fit themselves into that dress material which will be provided to them. And normal individuals like us will not get fitted properly. There will be some amount of odd points in that. So this modeling is basically the same. So let us say that your sodium level is 140. So you can go up to 148. Then you cannot keep that level of sodium during dialysis. Otherwise, what will happen? The sodium content of your body will increase, and then the patient will be having, if the patient is not on ventilator and conscious oriented, then this hypertonicity, the sodium itself will cause osmoreceptors to activate and cause intense thirst. And the patient will go into ask for more water. So that's why our aims and objectives is that basically that during dialysis, we have to keep the patient slightly less sodium content. What is the sodium content versus sodium concentration? Sodium concentration is your plasma sodium concentration. That is 140 milliequivalents per liter or 142 milliequivalents per liter, whatever you are saying. Okay. But sodium content is different. The sodium content is the total sodium in your body. Okay, so that is the sodium content. So in all the patients who are having congestive heart failure, nephrotic syndrome, chronic kidney disease patients, or the cirrhotic patients, they are having high sodium content. So that's why the sodium, whenever you will be keeping, that will be not alone always, it has to combine with the water. Always it will ask somebody to move the water to dilute it. Okay, our body is like that. Physiological response is like that. So if the sodium level in your blood goes up, you have intense thirst, you drink more water and dilute the sodium to your normal plasma osmolarity, whatever 140 sodium concentration, 140 to 145 milliequivalents per liter. So we have seen people going into this sodium remodeling and coming back with increased amount of weight gain rather than decreased one. It helps in short duration for treating the hypotension, intradialytic hypotension. But ultimately, what is happened, the sodium content increases and they ask for more water, they come back with more fluid in the body. So that is a problem with the sodium modeling, profiling. So that has to be kept in mind. Always those things should not be utilized. Only in selected few you can utilize. Okay, that is another one. Why tacrolimus ointment is used in case of itching? You said about itching. Persistent. Last sentence of naltrexone, tacrolimus ointment, and acupuncture. Why tacrolimus ointment? That is for Alok and Rishabh to talk about. If they are present, they can answer. Alok, are you there?
Hello.
Alok?
Hello.
Yes, Alok.
Hi, sir.
Why tacrolimus ointment is used in itching? That is called as uremic pruritus.
Basically, hello.
Yes, we can
Hello.
hear you.
Uh, so, must be it suppresses the cytokine release, sir, or
So why tacrolimus is given in transplant population?
to suppress the T cells. Hello. Hello.
So it is basically, it mediates the T cells.
T cells.
T cells activity. So uremic pruritus, whenever they did, it is a resistant phenomenon when there is no hyperphosphatemia or hyperparathyroidism is attributable, but still the uremic pruritus is going on. They took a biopsy of the skin and they found that there is intense T cell infiltration in the subepithelial layers, dermis and epidermis region, basically the epidermis region. So they thought that probably uremia per se is causing T cell mediated some reactions, which is causing this uremic pruritus, and they started using tacrolimus ointment, and they found a little bit better response to it. So that's why this tacrolimus ointment 2% has been advocated and found in pharmacy. Okay.
Yes.
Okay. Then another thing is seizure. You have talked about this one.
Yes, sir.
So seizure, you have said quite nicely all those parameters which are should be looked into when there is a hemodialysis related seizure. Okay, but most often what we see in our clinical practice is basically the inappropriate hypocalcemia. Why it is called as inappropriate hypocalcemia? So calcium level might be lower than the normal, little bit lower than the normal, or in the low range. Okay. But when you start the dialysis, so there are two fractions in your blood. One is the calcium. One is the bound fraction, which is bound to the albumin, the calcium, and the other one is ionized fraction. That is the ionic calcium. So what we do usually is total calcium, which is basically includes both bound fraction as well as the ionic fraction. Now, in case of metabolic acidosis, there is a conformational change happens in the calcium. It gets bound to the albumin more. And the ionized calcium, reverse is true. It is present in the ionized calcium more. Albumin bound calcium will be less. Whereas when your metabolic acidosis gets corrected to alkalosis, the ionized calcium, some fraction will go and bind with the albumin, and there is a relative reduction of the ionized calcium. Okay. So when we are doing dialysis, we are doing bicarbonate-based dialysis. So we are actually doing neutralizing the acid and causing after the dialysis, if you see, there are 2-3 things very important to be seen after the dialysis. One is the patient will be in metabolic alkalosis. Second one is the potassium level will be low in those cases. Why the potassium level is low? It is due to the movement of one is potassium we are taking out through the dialysis. That fraction is very low. It is not very high. But what we are doing is we are creating a metabolic alkalosis environment where the potassium will be moving inside the cell. Okay. So the potassium will be in the post-dialysis period will be tend to go low. So that's why we don't recommend routinely to do serum potassium immediately after dialysis. But after 2-3 hours or 4 hours, if you do potassium and if it is still low, then you can give some potassium correction. But don't give it immediately looking into the potassium, since there is a metabolic alkalosis which has been created by dialysis. Similarly, a borderline calcium should alert you where with metabolic alkalosis, the ionized calcium fraction will move and bound to albumin, and that will cause reduction of ionized calcium, which is the effective electrolyte, and hypocalcemia will cause seizures. So that is one thing which I wanted to emphasize in seizure. All other things are equally important, but this is more important in the sense that we always tend to forget this. Okay.
Yes, sir.
Okay. So seizures we have taken into account here. Okay, I think we have gastroparesis. Gastroparesis is another one you have said. Gastroparesis in normal non-diabetic patients can happen due to this mobilization of potassium, hypokalemia, which can happen during dialysis, and that can produce gastroparesis. Okay. I think that is, Reshma, you have done very nicely. I must say that it is a very good thought-provoking lecture itself, and you have done justice to it. And I am finding that it is getting better day by day. Rather, the type of presentation you are making is much more very highly thought-provoking. Okay.
Thank you, sir.
We should continue about the Alok's slides, or we can do it at a later period of time? I think we have discussed many. Now it is
Actually, it is, sir,
8:40.
almost same slides, nothing different. Only case scenario I've added. So can be taken later also.
Yeah,
Or
sir. I think we can take it later, sir.
Yeah, that will be better, I think.
Yeah, yeah. And
Okay.
Reshma, it is a very good presentation actually. Very interesting. I missed the initial part, but whatever sir has, I think these physiological concepts are very important for all of us, which we tend to underestimate in our critical care trainings. And so having sir here and getting those concepts clear is a big opportunity actually for all of us. So thank you, sir, for this
Thank you
beautiful
so much,
explanation.
Ketan. Thank you.
Thank you so much.
Thank you, Alok ji.
Can we
Thank you, sir.
conclude then?
Yes, sir.
Okay. So any questions from audience? Any other people want to ask any questions? To Resma or to me or to Alok or Ketan, whoever.
Was a question by Edwin that regarding to prevent intradialytic hypotension, passive leg raising, how helpful it would be to guide fluid removal and prevent intradialytic hypotension.
This is a very nice question he has asked. He has asked a nice question actually. Similar kind we do actually. Not leg raising. It is very cumbersome to do leg raising in a patient who is already cannot move due to AV fistula. One side is already fixed, and again you will ask them to do for leg raising for 4 hours. It's very difficult for them. Okay, it is not a convenient for the patient itself. However,
But reverse,
what we do is, let us say that a patient who is having autonomic neuropathy, that is one of the cause you have mentioned, no, autonomic neuropathy. Okay. So I have said earlier told you that there is a movement of water is required, venous refilling is required, which has to proportionate with the intravascular volume ultrafiltration removal. Correct. So when how you can increase the venous refilling? By few things. Likely, if the patient is having, we know that how the fluid is the fluid is managed inside our body. Correct. There are two forces. One is Stirling forces, and one is the osmotic forces. These two forces are interplaying to move for the movement of the water. Okay. So what is Stirling forces? Stirling forces is applied when there is a increased interstitial and intracellular pressure, which will be high, and the oncotic pressure will be low. Whereas in the intravascular compartment, if the Stirling force will be low, or the hydraulic pressure will be low and oncotic pressure will be high, then there will be movement of water from the interstitial compartment to the intravascular compartment. Confusing little? Or you understood? Let me know. Is it confusing or you have understood? Let us say there are two forces. One is oncotic force, which is present in the intravascular compartment. Another one is Stirling force, which is also present in intravascular compartment. Okay. Whereas in the interstitial compartment, there is a oncotic pressure as well as is the hydraulic pressure. So movement of water will happen if into the intravascular compartment, if the hydrostatic pressure is more in interstitial compartment and oncotic pressure is less, whereas intravascular compartment, the oncotic pressure will be more, hydrostatic pressure will be less. Correct? So giving albumin increases the oncotic pressure in the intravascular compartment. Whereas the venous pressure and the arterial pressure are always positive pressures. So it cannot be increased, the interstitial pressure cannot outweigh the intravascular or interarterial pressures. So how to increase the hydrostatic pressure in the interstitial compartment? The best way will be to put tourniquet or put crepe bandage over the lower limbs and the upper limbs, where you are increasing by external force the hydrostatic pressure, which is causing the interstitial hydrostatic pressure to rise more than the intravascular venous pressure, and thereby there is a movement of water from the interstitial compartment to the intravascular compartment. So this is another way of mobilizing interstitial fluid, or in those patients where the albumin is also low and you are dialyzing, still you are unable to achieve the ultrafiltration goal, you can increase the hydrostatic pressure by putting a tourniquet or putting the crepe bandage all over the body, especially in the limbs, and then mobilize the water into the intravascular compartment, and during dialysis you take it out. So this is a plausible procedure which we can do. So instead of raising the legs, we put tourniquet or any compressive bandage that will do the trick. So have I explained it properly, or still there is a doubt? Hello?
Yes, sir. Actually, Edwin is not right now in the group.
Okay, means you have already, you are convinced now? Means
Yes,
at
sir.
least the A part, physiological part.
Yes, sir.
Okay. Okay then. Bye-bye.
Thank you, sir.
Thank you, sir.
Thank
Thank you. Bye-bye.
Thank you, sir. Good night.